Hi everyone, this is your Dr. House of Pelvis, and the first topic we'll be discussing in obstetrics and gynecology will be pelvic organ prolapse quantification score. It has been one of the toughest score we have been trying to learn since MBBS, and even postgraduates find it difficult to understand the POPQ classification. The International Continence Society brought into this classification to quantify how much prolapse is happening from one patient to another. Usually people are writing cystocele plus plus, rectocele plus, but intraoperatively when they see after anesthesia, they see there is some more amount of prolapse that is being visualized, and how to prove to the patient that you had more prolapse before and you have been corrected right now. So to give proofs for this and also to compare different surgical procedures, we need quantification techniques. So that's when came into this POPQ classification. Let us get into pelvic organ prolapse quantification score. To understand it simply, we have a total of 6 points and 3 lengths. 6 points will be 2 points in the anterior vaginal wall, 2 points in the midpoint, and 2 in the posterior vaginal wall. And there will be 3 lengths, which will be genital hiatus, perineal body, and total vaginal length. So let us first understand what is the anatomy of genitourinary system. So when we first see, we have the uterus here. Here will be the bladder. And here will be the rectum. And now, these points, I told we have total of 3 lengths. First, to start with, we need to know POP classification is completely based on a structure called as hymen. So where is this hymen located? Hymen is just located below. This is a hymenal ring that will be there, 360-degree across the vaginal wall. And this hymenal ring, if you see from an anterior perspective, will be slightly corrugated like this, and we know there are multiple shapes of hymen. This is a normal shape in a vagina. So this will be the look of the hymen, and this will be looking like mucosal tags, something like that. And this is the reference system for POPQ. That is hymen based. Now we have 3 lengths. First length is total vaginal length. Why am I discussing this first? Because all the 8 other points and lengths together measured, except total vaginal length, is measured in complete straining or maximum Valsalva. So total vaginal length is the maximum length of vagina that is measured from the hymenal ring. So this is the maximum length, and we know the maximum length of vagina extends from the hymenal ring to the tip of the posterior fornix. So this will be the total vaginal length. Usually it's around 8 to 10 centimeter. Again, it varies depending upon the age, depending upon the marital status, and a lot of other factors. This is the only length measured in resting state after complete reposition of the prolapse. Right? So we need to reposit the prolapse and then first measure with a uterine sound. You can just take the length of the total vaginal wall. Now coming to the second length, which is genital hiatus. Genital hiatus. Genital hiatus is the length between midpoint of, this is the external urethral meatus, the midpoint of external urethral meatus to the midpoint of the posterior hymenal ring, because the posterior hymenal ring will be this, and the midpoint of that is the posterior hymenal ring. So this length is called the genital hiatus, mentioned as GH. And the third length that we'll be measuring will be perineal body. Perineal body extends from the midpoint of posterior hymenal ring to the midpoint of anal opening. So this will be the anal opening. This will be the anal opening. So exactly at the level of anal opening is where this length's distal part comes. This is called perineal body. And you basically have an idea that this will be approximately around 1.3 to 1.5:1, so that the hiatus is not much opened up for the pelvic organ to prolapse. So in chronic prolapse or in old age, when the laxity happens, when the genital hiatus laxes up, the ratio of genital hiatus to the perineal body changes. Initially, the perineal body is of much larger length because perineal body gives the support to the pelvic floor. Upon laxity to the introitus, the genital hiatus length increases at the compromise of perineal body. So this completes the length measurements in pelvic organ prolapse. Now we'll go to measurements of points. So I told we'll be measuring a total of 6 points. So the 6 points will be point AA. Okay, how do we remember that? We have 2 anterior points, 2 mid points, and 2 posterior points, right? The small a mentions anterior, and if it is small p, it mentions posterior vaginal wall, right? Now the terminology goes this way. It's easy to remember. The point AA is a fixed point. It's a fixed point. Where is it located? It is located, see, this is the external urethral meatus. It is at a location 3 cm proximal to external urethral meatus in the anterior vaginal wall, right? So if I draw 3 cm from here, here will be the point AA, right? And this will usually correspond to the level of bladder base. So this is where the base of the bladder is situated. Why this is important? Because if there is some amount, see, this is the vaginal rugosity that is present. If this something happens below this point, you have urethra corresponding to it. If something happens above this, you have the bladder coming down. So this point descent will determine whether we are having a urethrocoele or we are having a cystocoele. Okay, let us go to the points first. So AA is a point in the fixed point in the anterior vaginal wall, 3 cm proximal to external urethral meatus, right? Now we'll go to the point BA. So the point BA, the point B everywhere in the system depicts most dependent point. So when we tell most dependent point, again the small a indicates of anterior vaginal wall. Just to remind you, as soon as I measured the total vaginal length, I asked the patient to do complete straining. And after complete straining, I check the genital hiatus, I check the perineal body length, then I come to the points. Right? So in maximal straining, I measured the point 3 centimeter proximal to the external urethral meatus is the point where AA was found, and BA is the most dependent point. The most dependent point in the anterior vaginal wall usually is 3 centimeter from the external urethral meatus. So that usually corresponds to point AA in normal patients. In normal women, it corresponds to point AA itself. So point BA is exactly at the point of AA mostly. It can never be below AA. Okay, that's how the vaginal mucosa is curved like that. And the curvature is the most dependent part, and this curvature is dependent most at the point 3 centimeter proximal to the external. Then comes point AP. The point AP, what I told about point A, it's a fixed point, 3 centimeter proximal to the posterior hymenal ring. Right? So this will be the posterior hymenal ring, and it will be 3 centimeter proximal to that. So it will be somewhere over here. So this will be the point AP, and BP is similar. B is the most dependent point, and the letter small p indicates posterior vaginal wall. So this is the most dependent part in the posterior vaginal wall. So this usually again corresponds to point AP. So usually point AP is at the level of point BP, which will be at a length of -3, which is anything that is at the axis of hymen is considered as 0. Anything above this is considered in minus. Anything below this is considered in plus. Okay, so point AA is usually at -3. Point BA is usually equal to AA and is at -3. This is the normal length which I am telling. The point AP will be at -3. The point BP, which will be usually equal to AP, which will be at -3. Right? Now we have two more points. That is, we have point C and point D. These are the two middle points. Two middle points. Right? So the point C is the level of the cervix. You know, the lowest point of the cervix will be denoted as point C, and point D corresponds to posterior fornix. So C corresponds to cervix, the most dependent part, and D corresponds to posterior fornix. So now tell me, we know the posterior fornix is formed when the cervix enters into the vagina. There is a groove that is formed there, and that groove forms the posterior vaginal wall. Now, if the uterus is absent, if there is no uterus, I will not have a fornix. So I will not have point D when I don't have a uterus. Right? So point D is absent in hysterectomized patient. And posterior fornix, why am I telling point C and point D as different? Why am I telling it's different? Because point D is the attachment of uterosacral ligament. So when the uterosacral ligament laxes, the point D comes down. The point D goes down here. This was the level of point D, and if the uterosacral support laxes, the point D tends to go down. And when point D goes down, the C point also goes down. Obviously, when the point where the cervix is entering into the vagina, if that is going down, this is the uterus. If this point is going down, obviously this point is also going down. C point is also going down. So what happens if the point D descends? The point D goes here, and the cervix also goes down along with it. right? This happens because the point D which was here came here, point C also came down. But if there is isolated point C descent, this is point D is still here, and if only point C is coming down, the most common cause, see in this condition, see here, usually you will see nulliparous women coming with something coming out of vagina. So if this condition happens, which is, what is this part? Cervix. So if the cervical elongation happens, the point D remains there, but the point C starts coming down. Understood? So why we gave two different points, point C and point D, is to differentiate between whether there is an isolated cervical elongation or there is a posterior compartmental defect at the level of uterosacral, or apical defect we say in this condition. Right? So these are the 2 points. So now tell me, we have discussed this basics. Let us now discuss what can be the values of these points. See, this is the bladder, this will be the anterior vaginal wall, this will be the uterus, and this will be the rectum. Now let us plot the points. Whereas first we reposited, we measured the total vaginal length. Happy? We got the total vaginal length, for example, assume it is 10 centimeter. Okay? Now, as soon as I have done, I asked the women to do a complete straining, do maximum straining in full maximum Valsalva. The prolapse is coming out to the max. Now I am measuring point length GH, which will be from external urethral meatus to the posterior hymenal ring, which will be GH. From posterior hymenal ring to the perineal body will be PB. Then I check the ratio. Great. Now I start measuring point AA. So where is point AA? It is 3 centimeter proximal to the external urethral meatus, you can say, or the anterior hymenal ring, you can say. If it is 3 centimeter proximal to that, it stays over here. And the point BA is, this is the hymen, vaginal rugosities that you are seeing here. If BA is usually here. Now tell me, the comparison between A and AP will be similar, so let us confine our discussion here to understand what can be the length of it. Now tell me, to what extent can this point AA go down to? Now tell me, this is the anterior vaginal wall, this is the uterus, this is point AA. I have told this is a fixed point which is 3 centimeter proximal to the external urethral meatus. Now tell me, if the point is here, assume this is the vagina, this is the external urethral meatus, and this was the point A. And when the vagina even completely everts out, this point, which was 3 centimeter proximal to the external urethral meatus, can maximum go to this point when the vagina completely everts in complete prolapse, but still this 3 centimeter will still remain as 3 centimeter here. So that's why the point AA can go from a minimum length of -3 to a maximum length of +3. It can never go below this. So now comes point AA extends from -3 to a maximum length of +3. Because it's a fixed point. I cannot go 3 centimeter below that. So it's a fixed point. So it can vary anywhere between this. Right? And if the point AA starts coming down, there is a component of urethrocoel with it. Because the urethra is somewhere below this. So if the point AA is coming down, obviously the part here starts coming down. So this is the part of urethra that comes along with the vagina in the prolapse. Now, in the point the point BA is the most dependent point in the anterior vaginal wall. Now what happens? In a complete prolapse, right? Assume the prolapse starts happening. Let us go step by step in a prolapse because it's a 3-dimensional thing that's happening. When the prolapse starts happening, this support starts loosening up. So now what happens? This point starts coming down, and this comes down along with a part of bladder in it, right? And Let us do it with a different color for easy understanding. This will be the bladder. This will start coming into it first, because anything that happens above the point of AA will first include only cystocele, right? So now this is coming, and this has taken a part of bladder with it, and here is my uterus that's getting attached, right? And now you tell me the most dependent part in the anterior vaginal wall is no more this point, right? See here, this is my urethra, this has taken my bladder down, and this point becomes the most dependent point. This will be BA, and obviously this is A, right? Because I am not touching the urethra. So this is the point BA that you are seeing here, and the BA has obviously come down, which means I am getting a component of cystocele with it. And now this BA can come to a maximum length of what? Let us assume, let us draw the diagram. This is the external hymenal ring. Like, this is this part which I am drawing here. Okay. If it completely averts out, 3 centimeter from this, see, it was proximal, now it's still proximal here. I have to calculate this way only. That's through the, towards the vagina. Here will be my point A, but my point, it may complete prolapse. This is the complete prolapse, right? And the bladder will be completely here. It will be completely here, right? This is the complete prolapse. And this point BA comes here. This is the most dependent point in the anterior vaginal wall. So this is the point BA, and this point BA will be a maximum length of what? The vagina can completely avert out like this and become like this, right? So this entire length of vagina will be the length of BA, because it's a length from the external meatus to the most dependent point. The most dependent point, the length will be total vaginal length. Am I wrong? Great. So BA is usually equal to AA, which will be -3 normally, and it can have a maximum length of total vaginal length. Great. The same concept applies in the posterior vaginal wall. So the point AP will have, usually it will be a -3, and similarly AP will have the same length below, so it will be till +3. While the point BP will be normally at the level of -3, but it can go to the total length of vagina, because the point, when in complete prolapse, if you see in this condition, in complete prolapse, the point BP comes here. The point BP comes here, and BP is almost kind of correlating with point D, because the posterior fornix also came out. Right? So the point BP will be the total vaginal length. So that will be the maximum level till which the point BP can go. Great. Now comes to point C and point D. So that's the beauty of prolapse now. The point C and D tells about the apical segment. So when you tell about the apical segment, so point C is here, point D is here. Whenever something happens in point D, the gut starts coming out of this area. Right? So point D tells about enterocele. So whenever there is a point D descent, you should comment about the enterocele, and this will have pulsations. So we will feel for some pulsations in the point D. And point C descent will indicate either a apical defect when point D comes along with it. When isolated point C comes down, it indicates simple cervical elongation. Understood? So now tell me, normally point C is completely inside, which will be almost equivalent to the level of total vaginal length. And since it is beyond this plane, so it will be minus total vaginal length in terminology basis, which we discussed here. Anything that is above this plane will be minus, anything below the plane of hymen will be plus. So the point C will have a length from minus total vaginal length, and in complete prolapse, as in this case, the point C has completely come out, and this is the plane of hymenal ring. So the maximum length the C can come down is plus TVL. No doubts with it. And similar goes with point D, which can go from minus TVL to plus TVL. Now, again, when the patient is hysterectomized, I do not have point D, but the vault that is closed after the hysterectomy the vault is considered as point C in post-hysterectomy patient. So post-hysterectomy we have point C, but we don't have any more point D. So once this is done, we will plot this into a grid system for easier depiction and understanding. Right? So the grid system is plotted in this manner, in a 9-box grid system, in which the terminology is A is here, B is here. Simple. This is anterior compartment. We know that. The point AP is here, BP is here. We know this is posterior compartment, so it is put down. Good. We know middle part is where the lengths are measured. That's how it is written. This is where genital hiatus is mentioned, the perineal body is mentioned here, and the total vaginal length is measured here. And the point C is measured here and point D is written. Okay? So we tell ABC and ABD is here, and in between we have length. So as soon as we start filling, the first length we fill is total vaginal length. Total vaginal length will be around 8 cm or 10 cm. So this is length. There is no plus, no minus in these lengths. It's always in centimeter and it is just measured in length. There is no terminology with respect to axis of hymen. Right? So genital hiatus will be written in centimeters, perineal body will be written in centimeters, and eventually the ratio of this will be calculated to know whether there is a reversal of ratio that indicates there is a laxicity of the genital hiatus. Then comes the point A. You know point A extends from a level of -3 to +3. The point BA will extend from a level of -3 to plus TVL. Similarly with point AP will extend from -3 to +3. This will extend from -3 to plus TVL. Right? And we know C point will extend from -TVL to plus TVL, and point D will be extending from -TVL to plus TVL. And if there is a, once this is plotted, we have the, now comes the staging of prolapse. So now, how do we stage prolapse based on this is, again based on the axis of hymen. This is the uterus, this is the hymen, this is the axis of hymen, right? Now the most dependent point, which means, how many points do we have? Most dependent. 1, 2, 3 and 4. The most dependent points is how much distant from the hymenal axis determines what is their stage of prolapse. Simple as that. And then we give nomenclature according to the staging. If the most dependent point, see we have a line, imaginary line that is drawn 1 centimeter above and 1 centimeter below the level of hymenal axis. Okay, so anything, the most dependent point, for example the point BA is here, that is the most dependent point is more than 1 centimeter proximal to the external hymenal meatus or external hymenal ring. More than 1 centimeter proximal to external, we can tell anterior hymenal ring or hymenal ring per se, right? If it is more than 1 centimeter proximal, this will be stage 1 prolapse. The uterus is coming down, for example, it has come down like this. The most dependent point is here. The most dependent point is more than 1 centimeter proximal, so this will be grade 1 prolapse. Simple. So you see this, right? And you got an idea, okay, total vaginal length is 8 centimeter. The point A is still there in -3, but the point B is just started to come down. From -3 it came -2. It's fine. It's still, a total of 8 centimeter from here, and 3 centimeter there is thing. So I have total of 5 centimeter fall. That's allowable. Till then it will be stage 1 prolapse. Now you have 7 centimeter fall because 0.3 centimeter is your point A is 3 centimeter from the external from the hymenal ring, and at the level of 1 centimeter is where I am having the cutoff. So if it is above that level, it will be considered, which will be around this length will be 7 centimeters, right? So till this it can fall, it will be still stage 1. Great. And now when it just comes into this plane, when it comes just below the level of 1 centimeter, the most dependent point comes less than 1 centimeter from the external hymenal ring. It is less than 1 centimeter from external or just the hymenal ring, right? Just 1 centimeter from the external hymenal ring, above or below. 1 centimeter above or 1 centimeter below from the external hymenal ring. If the most dependent point is here in this area, if I have the most dependent part, then I will call it stage 2 prolapse. Right? Now, the most dependent point is more than 1 centimeter from this is the 1 centimeter from the external hymenal ring. If it is below the 1 centimeter margin, so the prolapse has come beyond this line. This is the external hymenal ring. Again and again I am telling you, this is the external hymenal ring axis, and 1 centimeter below that. And if the most dependent point is below this level, that will be called as stage 3 prolapse. But it should be. See, the maximum prolapse that can happen is the entire vaginal wall can come here. Assume that happened. Okay, assume the entire vaginal wall came here. This will be the total vaginal length. This will be the total vaginal length. And I just have another plane where I subtract 2 centimeter from the total vaginal length. So anything that is 1 centimeter below the level of hymenal ring till TVL minus 2 centimeter. So this line I can tell TVL minus 2 centimeter. Am I wrong? Any doubts? No. This is TVL. The vagina which was here came out completely, and just 2 centimeter below that I drew a plane, and this plane will be TVL minus 2 centimeter. Any prolapse that happens at this level will be stage 3 prolapse. And if the most dependent point goes beyond TVL minus 2 centimeter till maximum TVL, will be stage 4 prolapse. And once this is done, you will plot, you will do the staging. How will you do the staging? You will exactly communicate to a person that, for example, the point BA has come down so much that the point BA has come to the level of, it was at the level of minus 3, it came down, and it came down here to a level of minus 2 or minus 1. Then I'll plot it at minus 1. So if B is at minus 1, then it is coming under stage 2. Right? It is at minus 1. If it is just below minus 1, or for example say minus 0.5, this will be stage 2 prolapse. But stage 2, where what prolapse? Anterior compartment prolapse. So now I know to what degree the cystocele has come down. Right? So how do I document that? Stage 2 BA indicates the anterior compartment is having stage 2 prolapse, and for example the point C is still there, it's not coming down, the point D is still not coming down, then it is an isolated cystocele that has happened. Then you can decide to just correct the cystocele. You don't have to do hysterectomy in these patients. If there is a posterior compartment defect, then it will be added up. For example, there is this third stage posterior compartment defect, so you add stage 3 PP, and then you say how much C is descended, how much D is descended, and once D you comment on the pulsations of D. So by this you will quantify how much the prolapse has happened, and post surgery you will again do the scoring to tell the patient, see, your point BA was at minus 0.5, which was the most dependent point, but I have corrected the cystocele, I have reposited back, I have made sure once the vault is closed, I have made sure the point AA corresponds to BA, and it has gone back to minus 3. So I have completely restored. This is the functional quality of this scoring. So this compiles what is pelvic organ prolapse scoring, and I hope you understand that. Any doubts, please ping me in the comment, and I'll get back to you as soon as possible. Thank you. Keep learning. Keep teaching.